in Africa. Well, I'm very honored to be with you with this review about the indication for cardiac pacing. And I would like to start with my cornerstone message, or the main message of this presentation, that the optimal cardiac pacing management for patients with symptoms suggestive of bradycardia starts with these 4 parameters: a thorough history taking, cardiovascular risk, complete history of focusing on symptoms, family history, comorbidities, and concomitant medical treatment, the physical examination of the patient and the assessment of the perfusion, the ECG criteria, and the cardiac imaging and results of structural disease. And by these 4 parameters, we will see our format for this presentation is case scenario based, so that a tiny difference or changing one of the details of these 4 parameters would change your perception of the case and your reflection, and hence your decision making according to each case. I'm sure you are all aware of all the facts we're covering in this presentation. What we will be trying to do is to cover as many points, to be as comprehensive as possible, to organize our thoughts from the entry of the patient or the initial presentation of the patient until the diagnosis is made and the definitive management is decided and implemented. So bradycardia can be classified into persistent bradycardia. So ECG, resting ECG will be easy to document at any time the resting ECG is made the bradycardia, or paroxysmal bradycardia, which is a group of paroxysmal blocks or sinus node disease that are paroxysmal and needs further investigation to be either documented or non-documented by highly suspected related to the symptoms. And let's start with the first class, which is the persistent bradycardia. This is our first case, and as I mentioned, we will be changing from this first model small details regarding these 4 parameters and see how this will change our reflection and how it would change our decision making. So this is a 70-year-old male patient with multiple cardiovascular risk factors. On examination and presentation, he was complaining of aggravated dyspnea in the previous days. On examination, he had maybe reflex hypertension with a heart rate of 35 beats per minute, equal air entry bilateral, mild lower limb edema, and lax abdomen. His echocardiography shows preserved LV systolic function with an estimated ejection fraction of 55%. And this is his ECG. And it's a classical, simple example of high-grade or high-degree AV block, where we can see an AV association and AV evidence of AV conduction, but with 2 or more blocked P wave non-conducted to the ventricle. And this is a classical second-degree Mobitz type 2 AV block. Same is complete heart block, considered as an example of high-grade and complete heart block, where there is complete dissociation between the atrium and the ventricle, as we can see in this ECG. And this, again, is an example of high-grade, considered complete, considered of significant pathology and significant percutation on the patient, either having an advanced or high-degree second degree with more than 2 consecutive P waves blocked, or a third complete heart block. So the question now is, what is our next most appropriate management step for this old patient, multiple cardiovascular risks, and having a complete or high degree AV block? Would you go for chronotropic medication? Would you go for temporary pacemaker insertion? Or you will need further assessment to better decide? And the right next appropriate management step would be further assessment, since temporary pacing is as cited in the latest guidelines and many previous guidelines, is only reserved to hemodynamically compromising bradyarrhythmia to which you have tried intravenous chronotropic drugs and were refractory. And the reason for this recommendation is that insertion of a temporary pacemaker is considered a high-risk procedure with procedure-related complication, including cardiac perforation, bleeding malfunction, arrhythmia, and accidental electrode displacement, also related to the patient immobilization with increased infection, thrombotic events. In addition, it was linked to increased risk of permanent pacemaker infection. So the question now would be, how would I assess the perfusion status and the need for chronotropic or temporary pacemaker? Would you rely on blood pressure limits? Would you rely on a cutoff point of heart rate, or on clinical and laboratory markers? And actually, this question is to emphasize that there is no blood pressure limit for perfusion, means that the patient could be hypotensive but well perfused. Also, with a decent heart rate above 50, he could also, through a complete or an advanced high degree block, be also hypoperfused. So the right approach would be a clinical and laboratory markers to evaluate the function of the organs, starting from the conscious level, the respiratory rate, the urine output, the decline in renal functions, the presence of acidosis in a blood gas or an increase in lactate. So all these measures and maybe echocardiography measures that can help you to assess the perfusion status of your patient. So now your patient was assessed and you have judged he is hypoperfused. Patient has what? So you are deciding to go with chronotropic medication as per the guidelines. Which of these chronotropic medication would you use, knowing that the patient has a history of high-grade narrow-angle glaucoma? So the appropriate reflection here, despite atropine is the universal chronotropic drug to be used in most patients, it is contraindicated in patients with high-grade glaucoma. Norepinephrine doesn't give you the chronotropic effect, but a vasopressor effect, leaving you short with dopamine. So you gave your medication, the patient has not responded to the medication, still hypoperfused, and you decided to go for temporary pacing, knowing that you have in your facility a cath lab giving you the privilege of fluoroscopic guidance. Which would be your approach for access for your temporary pacing? Femoral approach, jugular approach, or subclavian approach? Having this fluoroscopic guidance and with lack of preference and let's say strong evidence about the preference of which access to choose, but we can follow the guidelines that intrathoracic subclavian puncture should be avoided to reduce the risk of pneumothorax and to keep the subclavian vein free for possible permanent pacemaker implantation. Jugular access could be of preference. Go ipsilateral, contralateral if you are going to do a subclavian or an axillary puncture for your permanent pacemaker. And for selected patients, since you have the fluoroscopic guidance, you can go femoral access, but owing to the instability of the passive lead, the temporary lead, the duration of this approach should be as short as possible until either bradycardia is resolved or a permanent pacemaker is decided and implanted. What if we change this tiny detail in our case scenario, which is the case in many of our peripheral hospitals in Africa, where you don't have a cath lab or you don't have a fluoroscopy guidance? Would that change your choice of the axis using echocardiography guidance? So echocardiography guided femoral approach, jugular approach, or subclavian approach. And this tiny detail will change also your reflection and hence your decision making, since subclavian has been excluded for the previously mentioned reasons. And now the femoral 2 is excluded since the difficulty to visualize its ascendance into the cardiac silhouette. And this is an example of this skill of visualizing the temporary lead advancing from the right atrium into the right ventricle and up to the RV apex. It's a skill that we should transmit to our fellows. It could be life-saving for those working without fluoroscopic guidance in periphery. Also, using echocardiography guidance can help in the jugular vein puncture and access, visualizing the vein and hence minimizing the complications, the hematoma and other complications. And maybe this is one of the few studies comparing echo-guided approach versus fluoro-guided approach. And as you can see, the rate of complication had no difference between both approach. Maybe there were a significant improvement in the rate of time for the procedure in favor for the echo-guided, and also complication delaying more than 48 hours the permanent pacemaker insertion was also in favor of the echo-guided approach. So it's a skill that we should follow and transmit to our fellows. One of the tools that can help is the balloon-tipped floating catheter, as a catheter or a temporary lead, which is easier to insert, more stable and safe than the semi-rigid catheter. And the idea is to inflate the balloon once the lead is in the vein, in the jugular, and it goes with the flow into the RV. And once in place, you deflate your balloon and secure the lead. What we have in most our countries, and especially what we use, is a semi-rigid catheter or temporary lead. Also, in some cases, when it's expected to have a long period of temporary pacing, like in case of endocarditis or valvular infection or pocket infection, you can secure your patient with active fixation lead connected to a external permanent battery until time elapsed, infection resolved, sepsis resolved, and then you remove the whole system and implant your permanent pacemaker conventionally. So now back to our scenario for this 78 years old patient. He has complete heart block. Your temporary pacemaker is in place. Now it's time to exclude the reversible causes for his bradycardia. And this is a reflection for all patients. Once you are having a patient with a permanent or a bradycardia that is documented. So which of these medication might cause bradycardia? Phenytoin, ticagrelor, corticosteroids. And as you can see, these are not the typical list of medication to which we think. The three of them are described to cause bradycardia, and this is a list. We are always focused on cardiac-related medications, but you have to know that other psychoactive, neuroactive drugs, chemotherapy, gastrointestinal medication, and other medications are also described significantly in some patients to cause bradycardia. And hence, again, emphasizing on the importance of thorough history taking, comorbidities, medication for your patient to be enlightened before taking your decisions. So the potential reversible causes of bradycardia include adverse drug effects, myocardial infarction, infection, surgery, and electrolyte disturbance. And that's why in the guidelines, it's a class 1 to do some laboratory investigation for the reversible bradycardia, including thyroid, including Lyme teeter, which is an infectious disease treated by antimicrobials, and reversible digitalis, potassium, calcium, pH, and other according to the context and the presentation of the patient to exclude the reversible causes. Apart from medication, there are a large list of intrinsic and extrinsic, like infiltrative disease, collagen vascular disease, infectious disease, extrinsic like electrolyte imbalance, metabolic disorders, neurological disorders. All these disorders can cause bradycardia. Some are reversible, some are not. And according to the presentation of your patient, according to the context of his comorbidities, you should be excluding and asking for more investigations to exclude these conditions and to have a definitive diagnosis and hence a definitive treatment. And here comes the role of cardiac imaging, which is to evaluate the presence of structural heart disease, sure to assess the LV systolic function and to diagnose potential reversible causes. And echocardiography for most patients is the main modality to do so. Yet, if we change the age of our case scenario, so a younger patient, less than 60 years, echo may be not sufficient, and further investigation and imaging is requested, like cardiovascular magnetic resonance. And the reason is to try to find the main etiology, like sarcoidosis, myocarditis, that could be reversible or not. Also, the other benefit of doing so before taking your decision and before implanting your permanent pacemaker, first, if you find something reversible, so you will defer the decision for pacemaker. But even if it's not reversible, after implantation, it will be difficult to do the cardiac MRI, even with the MRI compatible devices, since the implantation of the battery can in the precordium makes it a significant artifact to interpret a cardiac MRI after implantation. So it's always interesting to do, if possible, this modality of imaging to better diagnose younger patients less than 60 years. Of course, if you suspect ischemia, you will ask for CT or coronary angio. And this is the guidelines. It's a 2A class for patients younger than 60 years to do further imaging modalities. Back to our patient. No reversible cause of bradycardia identified. We are in day 2. You do your routine round and you put your temporary pacemaker off to examine the intrinsic rhythm of your patient. And he is always in complete heart block with a decent heart rate of 50 beats per minute. He's now completely asymptomatic, well perfused. With the pacemaker off, what would be your next decision? Would you remove the temporary pacemaker and follow up the patient, implant a permanent pacemaker, or perform an EP study to better decide? And the next appropriate decision would be, this is the ECG of the patient now. You see the complete heart block. So implant a permanent pacemaker. And as we said, our example is a patient with persistent bradycardia with a high grade or complete heart block. And these patients are indicated for pacemaker, permanent pacemaker implantation, irrespective of their symptoms. Irrespective of their symptoms. And that has been proven in the early studies of cardiac pacing, where pacing have had significance on the morbidity and the mortality of patients rather than leaving them with the significant high grade or complete heart block. This is not the case for milder form of bradycardia like sinus node disease or AV block of milder degrees, the first degree, the second degree Mobitz type 1, or the Mobitz type 2 with a single consecutive non-conducted P wave. These patients, according to the guidelines, needs to be highly symptomatic and to have their symptoms related to the bradycardia to be indicated for cardiac pacing. So now, which mode or device to choose? Single versus dual versus CRT for our patient. So back to the scenario. 70 years old patient, normal ejection fraction, no reversible cause. You decide to implant a permanent pacemaker. Which device is most appropriate for this patient? And the most appropriate would be a dual chamber pacemaker to improve the morbidity or the quality of life and to prevent or avoid the pacemaker syndrome, which is aggravation of the symptoms, dyspnea, edema, congestion due to the asynchrony or dyssynchrony between the atrium and the ventricle in case you put a single chamber. Single chamber or VVI pacemaker could be used in very old patients, more than 80 years, frail, with low expectancy and high risk for the dual chamber. CRT is here not indicated. What if we change our imaging result for the same patient and we had reduced LV systolic function with an estimated ejection fraction of 35%? Here we have a conventional indication with an LV ejection fraction less than 35% in a left bundle branch block patient, since you are implanting an RV, and you will, with the first beat or first pace, turn this patient into a left bundle branch block patient. So this is an indication for CRT. What if we increase a little bit the ejection fraction and we are out of the conventional indication for a CRT? We have now an ejection fraction of 40, 45. Would we go for a dual chamber or a CRT? We are out of the cutoff limit of ejection fraction 35 for the conventional indication of CRT. Yet we will choose again CRT, and that is based on the results from large studies, the PAVE, the Block HF, who studied patients with ejection fraction less than 50%, regardless of their NIHA class, who are expected to be paced the majority of time, an RV pacing of more than 60% of the time. This patient would benefit more with the biventricular modality rather than the RV-only pacing and its deleterious effect on the LV function. And this is a class 1A indication from the latest guidelines. And maybe this patient is a live example of this recommendation. 65 years old male patient. We received him with an ejection fraction of 40%. He had complete heart block. He was implanted by a DDD pacemaker in another hospital. 6 months follow-up, he had an RV pacing more than 90%, so a high degree of RV pacing, and the ejection fraction started to decline to 30%, and patient became more and more symptomatic. Decision to upgrade to CRTP, and here is the echocardiography, as you can see before and after, with global hypokinesia and significant mitral regurg, that with negative or reverse remodeling of the biventricular pacing have improved after upgrade to CRT in the 4-chamber view, in the long axis, and in the short axis parasternal view. You can see the difference immediately after resynchronization. The patient improved his ejection fraction over the follow-up months. Talking about biventricular pacing and resynchronization, we have to mention the growing interest in other modalities like pacing the conductive system for resynchronization and prevention of LV deterioration by RV-only pacing. And notably, we can talk about the left bundle branch area pacing, which is pacing or inserting or implanting your RV lead over the left bundle main trunk or the left posterior fascicle or the left anterior fascicle. And the advantage here is you get synchrony, you get biventricular pacing, and with a simpler and higher success rate for implantation than the previous technique of his bundle pacing. Perfect and excellent electrical parameters with higher longevity of the batteries, and it would be successful for blocks that are more distal to his bundle. So there is growing interest in this technique. Back to the scenario, and now our patient is 60 years old, so he's a little bit younger. He has an indication for CRT since he has complete heart block and an ejection fraction of 35%, but with thorough and further history taking, the patient reports multiple episodes of syncope, and it had a prodrome actually of palpitation and chest pain. knowing this patient is ischemic by history. So which device is most appropriate? Would you go for dual chamber? I believe not, but CRTP or CRTD. And through this high-risk patient with also a conventional cutoff point indication through the cutoff point of the LV ejection fraction of 35, he is indicated to add the defibrillator option into his implant. And actually, this is an element of debate. Yes, we have class 1A for the latest guidelines for patients who are candidate for ICD and are indicated for CRT. Implantation of CRTD is recommended, but you also have to be comprehensive, seeing the age of the patient, seeing the myocardial fibrosis, if you have done a CMR modality. The presence of other modalities would maybe go to CRT P rather than D, like non-ischemic cardiomyopathy, like a short life expectancy, poor renal function, patient preference. So this is a little bit debatable, but we have a strong recommendation for those who fulfill the criteria with an ejection fraction less than 35. Maybe the gray area above 35, which is a little bit more controversial. 3 months later, the patient is implanted with your CRTD. He's good. He left the hospital, and 3 months later, he calls the service because he's reporting receiving a first shock from his device. What would be your response for this call? Would you reassure him and follow up the next planned visit, or you would do an exceptional device programming at clinic, or you would recommend hospitalization because of this first shock? And the answer and the appropriate reflection would be exceptional device programming at clinic. For the first shock, we recommend reviewing the setting, reviewing the programming to make sure it's an appropriate shock, to do some programming adjustment according to the recorded episode. It doesn't require hospitalization, and for sure, you should not wait until the next planned visit. But this is for another course about programming, the follow-up of the pacemaker, and the different troubleshooting regarding this. Back to the pacing and the basic pacing course, we have talked about persistent bradycardia. Let's go to the other form, which is intermittent bradycardia. And we have two forms. Either it's intermittent or paroxysmal with documentation that needs further investigation like ECG, Holter, or monitor to be documented. Like this strip of Holter for a patient also complaining of recurrent episodes of syncope, of dyspnea, tachycardia, palpitation. And as you can see, there are runs of atrial fibrillation and long pauses. So the scenario is for a bradytachy episode. And the question is, what would be our decision for this patient? He is symptomatic, so symptoms are related to his bradycardia and tachycardia. What would you go for? So he's indicated because he's symptomatic, and we have documentation of the pauses and the bradytachy episodes. He's indicated for a pacemaker. The question is, which mode? Would you go for an AAI, a VVI, or a DDD pacemaker? And the most appropriate would be a DDD pacemaker. Actually, bradytachy form is the most common form of sinus nodal disease, usually associated with various forms of atrial tachyarrhythmia, including atrial fibrillation. And the pauses pathophysiology is either due to sinoatrial block, due to the fibrosis, or maybe due to overdrive suppression after atrial tachyarrhythmias. Most of these patients could be treated with pacing. There are other alternative approaches to cardiac pacing, like ablation of the atrial tachyarrhythmia, mainly atrial fibrillation. We have no robust evidence about which way to go, but this patient mostly will remain with the episodes of the bradyarrhythmia and symptomatic on these episodes after ablation. Another approach is dose reduction or discontinuation of the bradycardic medication, but again, many of them remain symptomatic over the bradyarrhythmia or the tachyarrhythmia, and they will need pacing and increased dose of their antiarrhythmic medication. The best is dual chamber for these patients. It's safer, more sustainable than atrial-only pacing, because as proven in the Dan-PACE trial on over 1,400 patients, AI was associated with increased risk of paroxysmal AF and of reoperation because of further development of AV block developing in about 2% every year when these patients were followed up for 5 years. So these findings support that these patients are at risk of advancing their sinus node disease into an AV block and hence will be reoperated for a DDD, and further is better to go for DDD from the start. Yet unnecessary RV pacing should be systemically avoided in these patients by algorithm for minimizing RV pacing, by programming a prolonged AV interval, but not too prolonged to cause diastolic mitral regurgitation, which can lead to aggravation of the symptoms and aggravation of the atrial fibrillation. So document the paroxysmal or non-persistent bradycardia. We've spoken about the intrinsic, about the documented. To document these episodes, you have to ask for more investigation, since the resting ECG might not declare the condition. So ambulatory ECG monitoring is one of the options. If the symptoms are frequent, Holter ECG would be recommended. If it's less frequent, like every month, external loop recorder, or now we have handheld ECG recorded and smart objects and smart recorders. If it's less than once per month, you are indicated for using an implantable loop recorder. And this is a class 1 recommendation. Yet in our countries, the high price of the implantable loop recorder make it difficult to really use. It's almost the same as implanting a pacemaker. Yet it's recommended. Other modality, you could ask for exercise testing, especially if the symptoms of the patient are related to effort, and that can reveal an infrahisian or infranodal block. Now for the non-documented but highly suggestive pathophysiologies. Bundle branch block and unexplained syncope. So if you have a patient, unexplained syncope, you have never documented episodes of bradycardia that would explain the syncopes, but having a typical bifascicular block pattern, like right bundle branch block with left axis deviation, denoting a left anterior fascicle block, or a less common bifascicular block through the block of the right branch and the posterior fascicle, manifested as right axis deviation. These patients also can present or can progress into the pseudo-fascicular block, which is right bundle branch block, left axis deviation, and first degree block, and they are all in high risk to develop the true trifascicular block, where you can end with third degree heart block and significant high grade block. So for this patient, the algorithm to follow is, you have a patient with unexplained syncope, but he have bundle branch block, true bifascicular block. If he has an LV ejection fraction less than 35 with his bundle block, he is indicated for a CRT. If he doesn't, if he has a preserved LV ejection fraction and he's too old and frail, you are justified to implant your pacemaker because the high risk of trifascicular or complete heart block. If not, and he's younger, you have to go for EP study and make your diagnosis accordingly if you have infranodal or significant block. And that brings us to the subject of the role of electrophysiological study in bradycardia. Its role has reduced with the emergence of non-invasive ambulatory ECG technologies. It is indicated when the bradycardia is suspected to be the answer for the patient's symptoms, but has not been documented after non-invasive evaluation. And the goal is to identify abnormal sinus node function, or most importantly, to identify the location of a cardiac conduction disorder, an AV block that is nodal or infranodal. You do it by recording the intracardiac signals from the right atrium, the right ventricle, and the His bundle, having a His deflection over the His bundle with an A and a V. And the idea is to measure the HV time from the first deflection of the His, from the early His, until the early ventricular activation or activity over the surface ECG. And by measuring this HV at baseline and with stress by incremental atrial pacing or by pharmacological provocation, the development of intra or infrahisian block is of a positive predictive value of up to 80% to identify patient who develops AV block and explain their symptoms. The prognostic value when the HV is between 70 and 100 is 12% risk for AV block in 4 years, and up to 24% in those having the HV time more than 100 milliseconds. And hence, it is recommended in patients with syncope and bifascicular block who are not very frail, who are not with an ejection fraction of less than 35%, to identify the location of the block and the risk for developing the complete heart block. In patients with syncope and sinus bradycardia, we have lesser indication. It's a 2B. And to better understand the role of electrophysiology in these patients, it is best efficient when the patient is at high risk, means he has sinus bradycardia, he has fascicular block, he is suspected for tachycardia, and its efficacy is lowest in patients with syncope and normal ECG, no structural heart disease, and no palpitation. In other terms, if your patient is at high pretest probability, EPS is better than implantable loop recorders. But if your patient has no structural heart disease, normal ECG, implantable loop recorders are preferred over EPS. Another important fact is a negative EPS does not exclude an arrhythmic syncope, since approximately 1/3 of patients with a negative EPS in whom an implantable loop recorder is implanted developed AV block at follow-up. 1/3, it's a significant number. Another rare condition is the alternating bundle branch, and a patient to which you have ECGs that shows right bundle and other ECGs that shows left bundle branch block, or bifascicular block over the two fascicles, like right bundle branch block with anterior and sometimes with posterior fascicle block. These patients are at very high risk to rapidly progress toward AV block, and they are indicated for pacing even in the absence of symptoms. Lastly, the reflex syncope. So these patients identified by a tilt table test by a cardioinhibitory response, which is a class 2A to request this patient this exam if the patient presents with symptoms that orient us towards reflex syncope. And this is an example where the patient started to be bradycardic on the tilt test, and finally a huge sinus pause. It's important, your reflection for these patients, that cardiac pacing should be last resort and should only be considered in highly selected patients. Means they have to be more than 40 years of age, of course, and mostly above 60 years, and affected by severe forms of reflex syncope with frequent recurrence associated with high risk of injury and without a prodrome. So it's not always cardiac pacing for these patients. So above 40, highly symptomatic, severe form, recurrent syncope with symptoms and a pause more than 3 seconds, or asymptomatic with pauses, asymptomatic pauses for more than 6 seconds. Now, for few other examples and special considerations like this ECG. It shows a complete heart block, and also it shows inferior infarction. So a 65 years old patient, third degree AV block, recent inferior acute myocardial infarction, LV ejection fraction 50%. And the question is, he is well perfused, no need for temporary pacing, but the question is, what is the next most appropriate management step? Would you go for immediate permanent pacemaker implantation in this patient? Or would you wait for 3 days follow-up until you decide if it's persistent, or 5 to 10 days? And this is to show that in these patients, especially with inferior acute MI, AV block is located above the His bundle in most patients, while in anterior MI, it is infra-Hisian. Most of these patients would resolve. Revascularization is the main treatment for these patients, immediate and complete revascularization. They are vaguely mediated, so they would respond to atropine. They may require temporary as the other indication, but most often resolve spontaneously. We wait up to 10 days before implanting a pacemaker in these patients, but this period can be shortened to 5 days if these favoring considerations are present, like unsuccessful or late revascularization, anterior MI, as we said, bifascicular block or AV block before the myocardial infarction, so from the history, progression of AV block within the first days after myocardial infarction. What about post-cardiac surgery? And it's mostly post-valvular surgery rather than CABG surgery that we can be confronted with a bradycardia problem. An observation period of 3 to 7 days is usually applied, but also there are favoring consideration for earlier pacemaker implantation than 3 to 7 days. In case the block came in the first 24 hours and persisted for 48 hours, the resolution is unlikely, and in case of complete AV block with low rate of escape rhythm. A special consideration with the tricuspid valve surgeries, to avoid damaging repaired tricuspid valve or bioprosthesis, we should avoid the use of transvalvular lead implantation and favor coronary sinus lead or minimally invasive epicardial leads for these patients. If also the patient had an existing RV lead before the operation, it's better to remove it and implant an epicardial RV lead during the surgery in order to prevent tricuspid damage and also to prevent damage to the lead and hence problem for reoperation. That gets us into the leadless pacemaker. We know it exists now, and the only indication, hard indication with a 2A, is considered for patient with no alternative venous access, or when the risk of device pocket infection is particularly high, as in patient with previous infection or patient on hemodialysis. Finally, with endocarditis, we also have to wait for the improvement of the sepsis, but we have predictors of AV block after surgery in endocarditis, like the presence of Staphylococcus aureus infection, intracardiac abscess, or tricuspid involvement of previous valvular surgery. And as we said, in waiting for the resolution of the sepsis or maybe of the AV block, we can hand this solution for better fixation of the temporary lead. TAVI is another consideration. Efforts to minimize unnecessary permanent pacing are warranted, and we know that the incidence of AV block ranges from 3 to 25%, but it's very important to, the main predictor is the presence of right bundle branch block, and hence procedure planning during the implantation should be taken once the patient has been identified preoperatively to have a right bundle branch block, among other characteristics that could be predictors of permanent pacing. We have covered most of what I wanted to tell you and to organize our thoughts together. Depends on the presentation of the patient according to the 4 main parameters: history, physical examination, 12-lead ECG finding, and cardiac imaging. You will be confronted with persistent or paroxysmal bradycardia, and you will have multiple scenarios. You will ask for further investigation to have your definitive diagnosis and accordingly put your final decision for the best interest of your patient. I would like to finalize with my first slide. It's the main cornerstone home-taking message. Optimal cardiac pacing management relies on your thorough history taking, physical examination for the perfusion assessment, the ECG finding, and cardiac imaging. Every single detail in these 4 parameters will change your reflection and hence your decision making for your patient. And by that, I thank you very much.
Thank you.